introduce Gerard Hanratty, who's going to talk to us about the impact of the Health and Social Care Bill on the NHS. A very timely presentation. Gerard is Head of Health at the UK law firm Brown Jacobson, and Gerard is regarded as one of the leading public law lawyers in the country, currently advising on the health and care sector. So Gerard will be doing a Chris Whitty as I will be managing his slides. So there will be lots of next slide, please. So bear with us and I'll hand over to Gerard. Thank you.
Thanks, Janet, and thank you very much for the introduction. It's always helpful when I get to write my own introductions for people to read without having to make sure that I give any evidence of them. So what I'm going to try to do today is go through just about the entirety of the white paper. So it'll probably take me about 30 to 40 minutes. But then after that, I'm quite happy to answer questions. And if people have any specific questions or want to have a little bit more look in depth at the different parts of the white paper, then I can also let you know that on our YouTube page for Brown Jacobson, we actually have currently 3 separate webinars dealing with the first 3 parts of the white paper, and the 4th part of that will be done on Friday. So they're a bit more in depth. And actually, if IMAS want me to come back, I can talk to you a little bit more about the structure of an integrated care system. But to be honest, I'd quite like to see what the guidance and the actual bill has to say prior to doing that. So can I have the next slide, please? Thanks. So this is just a pretty straightforward slide, just to give people the history of how we have got to where we are. So I'm sure people will recognise, if you've never seen it before, that was the original NHS bill back from the 1940s. But where we are currently is that in September 2019, NHS IMAS made a series of recommendations to the system as to how we could move through to integrated care. And we then had the pandemic hit. And so they didn't get put on the back burner so much as they were no longer a priority. The priority was dealing with the pandemic. And whilst I think work was still going on around integrated care, and you know, not least due to actually dealing with the pandemic itself, they weren't advanced in the legal way of preparing a bill, a white paper, and that. And so that went a little bit quiet for understandable reasons. Then in November 2020, NHSEI issued their proposals for integrating care. And from this, what we saw was that, and I think with influence from both the Treasury and from the department itself and the Secretary of State, that they were now starting to think more about a change to the current statutory bodies within the system in order to actually create a statutory integrated care system body. And as I say, I think Treasury were influencing that because we know that they didn't like money being paid to this policy-based body, which was what STPs, ICSs were up until, or are up until April 2022. So with that influence, they then suggested, should it be a joint committee across the system or should it actually be a separate body? And what we've seen in the white paper, which was issued in February 2021, is that it is now going to be a statutory body. The bill is due anytime soon. Spring goes for quite a period of time, I think, in government speak, but I think given that we want this bill to become an act from 1st of April 2022, really to get it through Parliament, the bill needs to come out within the next few weeks, really, because obviously we'll also have the summer recess going forward. So hopefully that will all be happening as we go forward. I think if people can't see the slides, by the way, if you look down at the bottom, if you're looking at my face, you need to click on where you can see the actual slides, and then that should come up in the middle of the screen so that people can see it. It's just so I'm not running them, Janet's running them. And that's why if you've got my face in the middle of your screen, I'm afraid you need to click on one of the different pictures at the bottom of your screen, and that should bring up the slides. Next slide, please. So the white paper proposals themselves are split into four separate areas. So the first is working together and supporting integration, which is essentially where we get the majority of the proposals over creating an integrated care body. Then we have reducing bureaucracy, which is looking at making sure that NHS merge, that that we get rid of the proposals around Section 75 of the Health and Social Care Act, so procurement, patient choice and competition, and actually put in place a different system, enhancing public confidence and accountability, which is probably actually where the NHS merging one is, and the additional proposals. We're going to go through all of them, so I'm going to go quite rapidly through them. And what are the aims? So we've spoken to the department a bit and to their policy advisors over what is happening, what the intention is, and they've been really clear throughout all of the discussions I've been involved in that the aim is to make the patient voice central in the system, and that shouldn't be forgotten in creating the new system, that this is what it's really about. They want the system to be permissive and flexible. I think the three watchwords from Simon Stevens help with that on the basis they're followed through with, which is simple, local, and evolutionary. Because if we try to rip up everything that has gone before, then it's going to take a lot of time to implement a new system. So I think there will be flexibility, and that systems themselves will be able to look at how the governance best works in their area and how they can actually make sure they can manage the service provision going forward. But again, to be honest, we are waiting for the detail on that. My understanding is that there are currently two groups operating. So one is very much working on the detail of the bill, and the other is working on the detail of the guidance. I understand guidance will start coming out now, even though the bill will just be going through Parliament as opposed to waiting for the bill to get royal assent. So we should start to have some greater information coming forward in the next few months and weeks over what the intention is, especially around the actual creation of the ICS itself and what its governance and makeup should look like. But the time frame is tight. 12 months, in fact, we have about 11 months now to implementation is really tight. And when we did CCGs, we actually had the Act at least a year before we actually moved to the new CCG. So we were able to start making the changes then. This time we don't have that. So there will need to be some resource put behind this by all of the ICSs, as well as NHS in order to get this over the line. Next slide, please. So let's just look at the first part. So working together and supporting integration. So establishing the integrated care system itself, which is one of the main points of the actual health and care bill. So the first thing to say is that it will lead to CCGs being abolished. I know they call it repurposing and that's what's in there, but the reality is that in legal speak, the CCGs themselves as legal entities and statutory bodies will be abolished and will be replaced, and their roles taken over by the integrated care system body. Now, that is going to be a standalone statutory body in itself, and the current understanding I have is that there will be two parts to it. So one part, which is where the NHS functions will sit, I think current thinking is it will be called the Integrated Care Board, but these names do change, so it may be something different in the bill, to be honest. But the Integrated Care Board is really going to be where the functions are exercised and where people are making decisions over how the system delivers on the expectations which have been set out within the long-term plan and will then move into the mandate and into what's contained in the new Act itself. In terms of membership of the Integrated Care Board, that is still under consideration, but I think from the white paper we can take that there will be some mandatory positions. So I think those will be the ICS chair and the ICS chief executive. There is also, I think, consideration about that also including a director of finance, which would make sense. And then there are representative positions which will come from one from an NHS provider, one from local government, and one from primary care. As to other positions on the Integrated Care Board, then so far as I understand it, currently there will be guidance over who should be on there, but that essentially this is part of the flexibility and permission left to the systems themselves to determine who they need there. I think two specific areas we have commented on are that there should be clinical input. So we would expect each system to give thought to a medical director and a director of nursing. And there is also then the concept of non-executive directors. So within the implementation guidance, you will have seen that was issued by NHS EI, there is specific mention of non-executive directors for the Integrated Care Board part of the new statutory body. It's not quite clear what that means at the minute. Are we talking about what we normally think of as non-executive directors, or is this about how people may be representing providers and local authorities and primary care? So some greater detail on that is going to be quite important, but I think generally people will have to think about the need for independent non-executive directors, because I think, as we have with other bodies, each ICS will need most probably an audit committee, especially given the amount of money that's coming through, and also a remuneration committee, given the fact that it is going to have employees that will need to be remunerated. And after that, I don't know whether it's going to be left to the system or whether they may decide that actually there should be a strong indication that perhaps you continue with primary care commissioning committees to keep a very clear link to primary care, because obviously we don't have generally separate statutory bodies that are delivering primary care. So I think the detail on that is going to be quite interesting as we go forward. The Integrated Partnership Board, so far as I understand it, will consist more of the other partners within the system itself. So it will have representatives from the Integrated Care Board on, will have local government on there. I think possibly that's where the elected officials may be. You would probably expect the executive officials to be on the Integrated Care Board to represent the local authority. We'll have public health on there, although part of me thinks actually public health should probably be more on the Integrated Care Board, to be honest. Also health and wellbeing board representatives, and then representatives from those who are not actually on the Integrated Care Board. So probably there you are looking more at the voluntary sector, charitable sector and independent sector, and how they can input into what's going on. As I say, this is kind of what I've gleaned as we've gone through, as we've spoken to various people, and just trying to share that with you now to give you an idea of what's happening. There is some tension, I think, with some of the role of the Integrated Partnership Board. So it will set a plan which the Integrated Care Board must have regard to in exercising its functions. But I think what many people have said is that they don't expect the Integrated Care Board to be accountable to the Integrated Partnership Board, that in fact they should work in partnership together, as opposed to there being any degree of accountability there as we go forward. So there is still a bit more detail we need to understand on how those specific aspects of the new statutory body are going to work. There are going to be new duties, though, on NHS bodies as well, which comes in from this part. So the one new duty is going to be to promote collaboration across healthcare, public health and social care system. Now, that is very much to try to step away from the competitive marketplace that is being created and the concept that providers are in competition with each other. So that will be a bit of a culture change for them. The other thing that providers who are licensed by NHS Improvement will find is that there is an intention the licenses will be amended in order to make it clear there is an expectation and requirement for collaboration. So that very much is going to be pushed into the system for people to adhere to, and will actually have a clear legal status to it. The other thing that is being put forward is the triple aim, which I think has been already put forward within the long-term plan. So better health and wellbeing for everyone, better quality of health services for all individuals, and sustainable use of NHS resources. I think everybody's looked at that now and can understand the basis for it. But I think one other part to it that may well now be added, although I don't know if they'll change it to a quadruple aim, is actually that the NHS should play its part with regard to environmental issues and zero emissions. I think that will become part of the overall aim of what's happening and probably be part of the sustainable use of NHS resources as well. Although I think a large part of that was originally directed towards how money is used and how buildings are used. Now, one other part, which I don't know how many of you have actually looked at yet, but we are looking at a lot more now when we're helping systems create themselves and looking at how they will actually make decisions through system, place. Many are now having localities as well, and then down into neighbourhoods. Are the different forums that are being created. So you can now have joint commissioning committees across ICSs, across providers, the ICS with a provider, with local government. So you have much better forums, legal forums within which to make decisions, and that will move us away from the use of committees in common, which we created, to be perfectly honest, as a workaround. Because when the Health and Social Care Act came out and amended the NHS Act, it didn't actually include an ability for CCGs to have joint committees. Whilst that was amended, this actually goes a lot further and also breaks down that barrier that has been created between commissioning and provision. So you will very much see that go away. And I think actually what you will see is that we talk a lot more about management within a system as opposed to necessarily commissioning and provision. But the use of those committees is important for people to think about, especially I think with regard to how you set up your place arrangements, if you do have locality arrangements, how those are done, and how you may decide that you want to involve other parts of the system in the way that you're making decisions. Will also help with specialist commissioning if that's delegated from NHS EI, because ICSs themselves can have joint committees too. Joint appointments is a bit more of a tricky area, if I'm really honest, because some have worked very well and some have not, that we've seen so far. But there will be a clear basis and guidance on which to think about joint appointments across the systems, and a very welcome improvement to the legislation will be a greater ability for data sharing, especially across health and social care, so that you can start to see the issues that are arising and how you can start to address them, and you have a greater understanding of them going forward. Hopefully that will also lead to removal of some of the complexity which is growing up over data sharing. Next slide, please. And then moving on to reducing bureaucracy. So the first main part to this is the repeal of Section 75 of the Health and Social Care Act. So as I'm sure, well, some of you may not, because I have to spend my time looking at all of the legislation, but this is the one which introduced the concept of procurement, competition and patient choice in a very clear way to create that internal market and to create that element of competition and to create a procurement obligation which basically went across all of the clinical services and non-clinical services that happen now. The intention is to repeal that and therefore to remove the internal market, because that's not conducive to the new purpose in terms of the integrated care system approach of collaboration. And so they want to, the government want to reduce down this competitive element and create a clearer ability for the NHS to actually go back to the way many of the European countries operate, which is that there is not this procurement element to those services which are available to the public. So that will remove the competition and clarify, and as you'll be aware, there has been a consultation on the new provider selection regime and how that can be implemented and how that can work. So I think that will be welcomed by a lot of the NHS. There will obviously have to be discussion with independent sector, with voluntary sector, charitable sector about how that all works together, but we'll hopefully remove some of that bureaucracy and some of the fairly large and frankly quite expensive legal cases that have been brought on it. And on patient choice, so far as I can see from what's in the white paper at present, there will be a greater move towards any qualified providers for some clinical services, so that patients can simply choose from a list that's presented to them, which will hopefully make that an easier way and will make it easier for both the independent, voluntary and the charitable and third sectors all to be involved in the way the system operates. Now, the ending of the current procurement regime will create some different approaches that the NHS is going to have to understand. So the commissioning of health services will come out of the public contracts regulations, but it is just the clinical services. The non-clinical services will still remain subject to those regulations. At the same time, there will be the introduction of the NHS provider selection regime. We're still waiting for all of the detail on that, but you've seen a lot of that detail over how those decisions are going to be made going forward, and will mean that the new ICSs will have to be very clear from the start how they're actually going to procure or make arrangements for those services to be delivered. And as I said, the non-clinical services will still be subject to PCR and subject to the Cabinet Office procurement rules. Now, that is also undergoing a consultation at the minute, and we expect new procurement rules to come out too. But what this should lead to is much greater flexibility for the system in terms of how it makes arrangements for the delivery of services. It also will enable and support the ability to commission or to make arrangements for care pathways, and will actually put probably greater emphasis on providers to manage those pathways and to manage by subcontracting with other providers how they input and how they deal with it all. In order to help with that, then there is going to be greater flexibility for local determination on national tariff. We have seen instances in the past where provider organisations have tried to work together on a more collaborative basis, only for one of them to say, well, this is all fine, but I want to be paid at tariff, please. And that obviously doesn't necessarily work when you're trying to work on a care pathway and there's only a set amount of money, and you're not working in the way that we used to. So there will be some movement on that, and that will take a bit of time, I think, to bed in. The other part that's within this is that the Secretary of State is going to take back his power to create trusts, NHS Integrated Care Trusts are what he's looking at, whilst he always retained the power after the changes under the Health and Social Care Act, because he's indicated within that he didn't want to use it anymore and that he wasn't going to use it. Then I think the department understandably were quite careful on what was done, because they felt there could be a challenge against them, because they had indicated that was not the intention going forward. So that's now available. Integrated Care Trusts can be created by the Secretary of State on application by any ICS, and he will also publish guidance as to what he expects each ICS to deliver. So again, a bit of a change in that you can go to the Secretary of State and say, this is what we want, this is why we want it, this is how it's going to help our system. Next slide, please. Enhancing public confidence and accountability has perhaps some of the proposals in it that have caused a greater degree of discussion as we move forward. So I don't think anybody is surprised at the proposal to merge NHS England and NHS Improvement. NHS Improvement still being two separate bodies of the TDA and Monitor into one statutory body. And I think my understanding is it's going to be called NHS England, but the discussion has been around, so what are its functions going to be now, and what happens with the direct commissioning functions, for example, that NHS England currently have? Will they be transferred to ICSs? How will that operate if they relate to a national specialised service? Will ICSs get all of primary care, pharmacy, ophthalmology? Is all of that going as well? So I think it will be interesting to see where all that comes out. I think there is an expectation that ICSs will have a greater number of direct commissioning or management responsibilities as we go forward. But again, that detail is still weighted. One of the interesting things, though, is if in NHS England keep any of those direct commissioning functions, then they do have the ability to create joint committees with ICSs and more than one ICS. Now, they do have that with CCGs, but obviously one of the issues we had with CCGs was that there was a large number of them, and so the geographical spread was much greater and you would need more on them. With this, there is a more determined geographical spread with ICSs. ICSs will be created by the Secretary, well, by an Act of Parliament, so not the kind of membership organisations which CCGs were. And that should make it easier to look at how specialised services can be run if NHS England retain that. In terms of the mandate, I think one of the things that's come through from the pandemic is that whilst the mandate is helpful to set the agenda and the objectives for NHS England, actually it can be a bit of a barrier when it comes to something like the pandemic hitting, because you can't change your strategic needs quickly enough. So I think what is now intended is that the mandate, there will always be a mandate in place, but there will be a mechanism that means it's more flexible and can respond to changing strategic needs as we go forward, so that objectives can be changed if something like the pandemic or something else were ever to hit again. The Secretary of State also, I think, now wants to move almost back to where he was prior to the Health and Social Care Act, in that one of the purposes of the Health and Social Care Act was to place the Secretary of State in a kind of oversight position that was more akin to the way that the Department of Education and Secretary of State for Education operated at the time in 2012. So to have more of a back seat, to be honest, from direct frontline decision making. I think through a mixture of issues that have arisen, the government think actually there needs to be a greater ability to take direct action and to have that direct input. And so what we are seeing now is an increase in the powers which the Secretary of State will have. So one of those will be the ability to intervene in service reconfigurations at any point that the Secretary of State chooses. To be honest, I think this is quite controversial. Certainly from the debate I've heard, it is a bit controversial because it will take away the power of local authorities to refer matters to the Secretary of State. One of the points put forward by the government is that actually the problem with that is those referrals always happen at the end. So when the decision has been made, whereas if they were made or could have been made earlier, then perhaps there could have been some mediation, there could have been some discussion, and the proposals could have been agreed so that changes which the NHS are clear and needed for clinical reasons are made. So that's one of the reasons put forward, but we're still waiting to see the detail of exactly what the Secretary of State proposes. And we have seen some recent interventions by the Secretary of State in some of the service reconfigurations that are ongoing. As part of this as well, I understand the independent reconfiguration panel is going to go, but there will be some new body put in its place, and the Secretary of State, when he does decide to intervene, is going to have an obligation to take appropriate advice and to publish that advice transparently so that everyone can understand the basis of the decision he makes. The Secretary of State is also now going to get a specific power to transfer functions to and from specified arm's length bodies. I think a lot of this, again, comes from the pandemic, like the mandate, and I think probably comes around some of the issues that happened with Public Health England and how those powers needed to be moved around for things like test and trace, and the new body that's actually going to be created to take on the Public Health England powers. So what this means is that the Secretary of State will be able to transfer functions from one arm's length body to another, and if he does that, he will also have the power to abolish an arm's length body if it no longer has any functions to exercise. And then one other thing, which again I think may come from the pandemic because of issues which happened between the ability for the NHS to support social care and how that could all operate on a workforce basis, is that once every 5 years, the Secretary of State will publish and set out the roles and responsibilities for workforce planning and supply. And this is going to cover NHS, but also between health and social care, to try and give some greater guidance, I think, to the system, and also to try to help with regard to the ability for the NHS to support social care, not least because obviously there was an issue over indemnity and insurance coverage too, which caused problems as it was apparent that social care and care homes were struggling and they needed support. So I think that's part of the thinking behind that, but will be something that everybody's going to have to take specific notice of and work out what their role is. And the other thing, which is a bit of a tidying up exercise, to be honest, a bit anachronistic, is to remove the current 3-year time limit on special health authorities so they don't need to go through that bureaucracy of having to be effectively approved again every 3 years. Next slide, please. The additional proposals part is quite interesting because it it wraps up a number of things. So it deals with some things that have been left over from prior to the pandemic, that have kind of been left in limbo a bit because of Parliament having to deal with all of the issues of the pandemic. It then deals with issues that have arisen as a result of the pandemic, where it's thought, actually, if we introduce this, it's going to help the system. And then the final bit being that it will then also, there's some introduction of some things to enable the system in a clearer way. So I think one of the things which is to enable, but has also been learned from the pandemic, is how to make the way that ICSs and adult social care work together much smoother, more integrated, and clear, and a clearer basis for them to make decisions so that they can share information. So we have, I think, and I have to be clear, this is my own personal opinion within health, created quite a complex way of dealing with personal information under the GDPR and the DPA. And I think to a degree that has also moved over into how we deal with all information. And I have tackled NHSX on this, and poor Matthew Gold, I asked several questions of at one session. And I think, to be honest, he agreed that we had created quite a complex system and we needed to make people remember what the actual legal duties are. And I gave him the example of, on occasion, and only really when this happens about data, and it's how it is going to actually be transferred, or how it's going to be used. I'll have fairly senior executives within the NHS ask me 3 times whether or not I'm sure that they can do that. And that just never happens on anything else, to be honest. So I think we have created quite a complex system, and hopefully there will be some greater clarity and some simplification of the way it can be looked at. Another interesting part to this is going to be the increased role for CQC. So as I understand it, CQC are going to have a duty to look at and inspect the way that ICSs exercise their functions, but also there is an intention they should have a duty to assess how local authorities deliver their adult social care duties. Now that means CQC are going to have a great overview of each ICS. Perhaps I should have just used the word, they're going to have a very good overview of how each ICS is operating. But what that's going to mean is that them working with NHS England and then working with the ICS is going to provide quite a wealth of information over what is happening and any issues that are happening within an ICS and how they may be approached and addressed. So that's quite an interesting movement, I thought, for CQC. The Secretary of State is also going to take on powers to make direct payments to social care providers. Now, I do think this is a direct result of the pandemic and the fact that we had social care providers who were struggling financially for understandable reasons as they were moving forward and needed some support. So I think that's pretty much understood. As many of you will know, that in terms of CHC and social care Act and social care assessments under the Care Act, then the system is moving away from the concept of assessment before discharge from hospital and is now moved to discharge to assess, so that beds could be freed up, especially during the pandemic, but it was already starting to move in that way. The legislation will now be introduced to give it a firmer statutory footing, because obviously the old system is still that which is set out in the Care Act and within the various regulations that govern the NHS. So that is a tidying up exercise too. And then because the mandate is going to be changed and turned into something which simply has to be in place and a bit more flexible, then there has to now be a new mechanism to set out the expectations for the Better Care Fund. And so the Secretary of State will be given a specific power outside the mandate to do that. When we then look at public health, so it's going to be quite interesting to see how this is used, because clearly at the minute the Secretary of State has his powers under Section 7A of the NHS Act to ask NHS England or CCGs to take on specific public health functions. But that's quite specific with regard to what can be done. And so now what's intended to be introduced is that the Secretary of State can ask NHS England to exercise public health functions, but also for those relating to obesity are coming into this in terms of what the Secretary of State can ask people to do. And on top of that, the Secretary of State can then take a direct role in the decision over water fluoridation, which has been one of those things which is, I think, has got some fairly interesting political issues with it, in terms of the debate that happens over it and as to its benefit. But the Secretary of State is now going to have those powers to step in on both that and obesity, as well as directing NHS England on the public health functions. And then when we look at safety and quality, so there is going to be the creation of the Health Service Safety Investigations Body. So we do currently have the HSIB, but the intention was to create that as a fully fledged statutory body, and that was kind of put on the back burner a bit when the pandemic hit. So that's going to take place. And the Secretary of State is within that going to have powers to ask them to look at specific issues of concern that may be happening within the system, which will be interesting. So at the minute, you may know they have a specific remit to look at maternity issues, very much, I think, driven by issues that have happened in Morecambe Bay, and also the stuff that Donna Ockenden is looking at in terms of Telford and Wrekin. But they are going to have the Secretary of State is going to have a greater ability to direct them with regard to what he wants them to look at. The Secretary of State is also going to take some greater powers over professional regulation. We're looking at the detail. We're looking to see what the detail on that is going to be. He thinks they will be used sparingly. I don't think he's got any great intention at the minute to use them, but he will have greater powers in that regard. Obviously, we've had to recreate in terms of it being a separate standalone organisation, the MHRA, because it was very much intertwined with the European body since Brexit. So that's being very clearly set out again. I know there are also new a new intention for new regulations and that to be set out over how they operate and how they manage over pharmacy and medical devices, but also new national medicines registry, which is kind of a byproduct, to be honest, of the pandemic itself, and how we can check to see what is happening with medicines and share that information. And the other things that are ongoing are the improved hospital food standards, which has been an issue for a little while. You know, we've seen all this stuff with one of the chefs. I remember his first name's Jamie. I can't remember his second name, which probably is quite appalling, really. But I can't remember what his second name is talking to you now. So those are stuff that he's been doing, especially with schools. I think he was involved with. The other thing that we need to tidy up since Brexit is comprehensive reciprocal healthcare agreements with the rest of the world, because they've obviously been quite intertwined with the European agreement, and so we need to sort out those. Next slide, please. So I know that's been quite a quick run through what's happening, and we're still waiting for the actual bill itself in order to see what that tells us, what greater detail that provides, and also the actual detail that the system is currently creating. But it will create the legal framework itself for integrated care systems. We've been using workarounds for a period of time now in order to have what I call a set of statutory functions which sit alongside a set of policy functions, which is the ICS. So actually creating clear statutory functions will reduce the risk of challenge on all of that. The removal of the internal market will make the application of collaboration and the integrated care systems easier, I think. The SAS is going to have greater powers over NHS bodies, which I know people will debate. But also the other benefit is that this bill will tidy up a number of outstanding issues which have come about through Brexit, but also from the lessons which have learned due to the response to COVID. So it will hopefully make the system much clearer in terms of how it's operating now, because at the minute there are lots of different bits you look at. So if I look at something relating to the integration of health and social care, when it looks at CHC and Care Act provision, then I can be looking at 10 different pieces of legislation in order to try to understand what's going on. And that inevitably leads to interpretation, and that can lead to disagreement. So hopefully bringing all of this together, making it much clearer, will help to clarity for the system going forward. The timeline, as I mentioned at the start, is quite tight, 12 months. And much will depend on the detail in the bill and the guidance that follows, which we're still waiting for. But we're starting to see hints of what is coming through. So if you look at the implementation guidance, that indicated the prospect of non-executive directors for integrated care systems. It also then specifically mentioned the the ICS constitution, which we're waiting for some detail on, and what that looks like in order to set out, we presume, how the governance arrangements will work across the system itself, in each individual area. So there have been some hints coming forward, but we are very much waiting for the detail now in order to move forward. And that is, I think, the complete presentation. As I said, I'm very happy to answer questions. I don't know if anybody's asked any questions yet. I am also quite happy if people would like to come back at some point in the future and actually go through what we hear about with regard to the detail on effectively part one, how we create the new integrated care systems. So now I think, Janet, it's back to you and any questions that may have come through.
Thank you. Gerard, could you just raise your thumb if you can hear me, because I don't know if I'm on mute.
I can hear you.
Good, super, thank you.
Oh,
Thank you very much. So
there you go.
thank you to Gerard for that excellent and informative presentation, and thank you for leaving us plenty of time for questions. Because we've got quite a lot of people on the call, if it's possible for those who can to use the raise hand function, because we will be able to have people interact with us and ask questions on the call. And I'm conscious there probably are questions too in the chat box. And so if nobody asks a question, I'll pick one out of there. But does anybody have anything that they'd like to ask right now in person? If you'd like to raise your hand, please.
Well, I can start with one if that helps, Janet, because
Thank you.
Christina's put in the question that I don't know if I can actually answer it really, Christina. I think if I do answer it, I have to be pretty careful. So what are the gaps in the areas of new legislation which might be missed? So I think when it comes to, let's concentrate on the main bit that we have to work with at the minute, which is creating these new statutory bodies, and what is going on there. So the things we've already looked at, to be honest, and I know is already in the minds of NHS IMAS and the DH, and I'm sure, if it's not in the bill, it'll be in the guidance, comes to, so where is the clinical input? We've had some suggestion over who should be mandated to be on the two parts of the ICS, but where's the clinical input coming? Because that's going to be key. What is the role of NEDs? Are we talking about truly independent NEDs, and how does that operate? I think the other parts are also around how do we get the primary care information into the system itself. So I think those are all things I'm sure everybody's working through and will all come through. I think so then when you move from the system, the other bit, and I don't think this is what I would call a gap, but I think it's hopefully part of the permission and flexibility, is that how you set out your place arrangements, subject to whatever is in the guidance that comes out, is very much open to the systems to work out so that it fits with how they operate, how their providers can operate, and how they've been working through the transition as it goes on, because everybody is working on the transition. And I think one thing which I hope they don't, that doesn't appear in the bill, is that there should be some kind of statutory body at place, because that would really cause an issue, I think. Now, I don't think that's intended, but I have heard people talk about, is that intended? And I have so far said, I don't think so. And I hope that is the case, because we have enough statutory bodies, to be honest. And if you have a system and you have the providers, and then we have the local authorities and everyone else, then we can make all of that work. And we're already doing that else in the system itself. So I think there are those bits going through. I think some of the other stuff that will have to be addressed. I remember having a discussion over conflicts of interest, and I found it quite interesting that it was suggested, well, the benefit of these not being membership organisations anymore is that we'll lose that conflict. Actually, without being funny about it, I think your conflict may actually be increasing a bit, because you're going to have a number of providers and the local authorities on there as well. So what you need to do is be very clear over the roles that people have on the integrated care system and the two bodies itself, because there is going to be a degree of conflict there. Even though there's more collaboration, They are still separate statutory bodies. They still have specific obligations to the body that they work for, that employs them, they're a member of. So I think the conflict of interest guidance will need to be rewritten. And I think actually, within that, what I would say, and something that happened when we rewrote some of the commissioning guidance on who pays, is the more practical examples you can put into that, the better, to get people to understand what you want and what you think. It takes away a lot of the uncertainty. So I think those are some of the things. I don't think that's really answering where are the gaps, and I'm sure we'll find gaps as we go through, but that's some of the stuff I would say.
Thanks, Gerard. There are 3 questions that have popped into the chat box, so I'll ask them on behalf of the participants, if that's okay. So the first one's come from Dr. Ali Hume, who is concerned that perhaps clinical directors, for example, nurses and medical practitioners, haven't been identified for membership of the new board so far. So I don't know if you want to say anything about the new boards.
So I think on that, I mean, one of the things is when you're working at pace and you don't actually have the legislation in place for you to understand, and the legislation is going to come online at the same time as the new bodies are created, it's not something we have really done in that way before. Normally we have a lead-in period. So I think what has been set out so far are the minimum expectations for the new parts of this new statutory body. But I think that within that, I mean, if you look at the implementation guidance, even now, there is still some debate over the appointment of the ICS chairs and the ICS chief executives. The extent to which everyone needs to go through an open and transparent process to do that. So there is still that going on. I think, though, that each system would be wise, in my opinion, to actually be looking at who are its effectively executive members of the Integrated Care Board, and how will that operate going forward. You all have a number of leaders in that, and if you need to create mechanisms to determine who it is, then you need to look at that. But I think, from what I've said to clients, is that I would seriously think about having a medical director and a director of nursing as standalone executive appointments for your ICS, because I think you need it. And I'm hopeful the guidance will contain that, but I don't know. I don't have any inside knowledge on that. I'm just hopeful that it will have that in, because I think it's beneficial. But I think in that knowledge, people should now be thinking about that.
Thank you. Next one from Andy Woodward, who's interested in the implications for information management, i.e. the new Transformation Directorate of including NHSX and NHS Digital from the Act.
Yeah, so, I mean, we've been having these arguments for a while, to be honest. I think we have created quite a complex system. And I don't make any apology for saying that. I think at times we allowed common law to almost take a higher position than statutory law, which is not the way that the system is supposed to work. So, when you looked at some of the stuff that was coming through around the expectations under Caldicott and all of that, from a purely legal point of view, and I'm not having a go at any of this, but from a purely legal point of view and a public law perspective, the position has always been that statutory law is that which is set by Parliament, who we have elected to run the country. They set it, and the gaps that are within those laws is what should be covered by common law. Whereas what it felt like is that actually the common law position was taking a higher position than the statutory law position, and that creates a wealth of problems. And I think what we did was we have created quite a complex system. As I said, I've never had a chief exec ask me 3 times whether I was right. They might tell me they don't agree with me 3 times, but they don't normally tell me that they're just not sure 3 times. So I think that was quite instructive. And to be fair, I think, when I mentioned this and raised this with Matthew Gold, he agreed we had created a really complex process. And what we needed to do was simplify it all. And that included simplifying the way that information could be shared across the system. And so I am hopeful that what we will see is much simpler guidance coming out, that the new Act will introduce a clearer basis on which information can be shared, and will also require people to share that information in a much easier way, so that there is no misunderstandings going forward.
Thank you. I think that picks up your question, Marion, as well, about plans for an integrated data sharing strategy, hopefully. We've got a long question from Joanne Wass. I'll try and read it out. Gerard, you can probably see it in the chat, but for the rest of the group, she says, I think that universities might say that given the learning from COVID, there are some gaps within the role of the Secretary of State and NHS bodies to promote and support research and innovation. This is most obvious on the data sharing section, which could usefully have simplified data sharing for research as well as patient care purposes. And indeed, the role of higher education partners in managing the workforce pipeline has been missed. I don't know if you've
Yeah.
got any insights into that particular
So
aspect of it, Gerard. Thanks.
yeah, I mean, I think one of the things is that we've known this has been an issue for a number of years. So um, I did a piece of work when we moved from SHA PCTs for the health system on the information which the system held and how to transfer it across. And the reality is the system holds a huge amount of information, but there has always been a nervousness with regard to how that information is shared. Um, and also a nervousness, like some other countries, on the concept of a commercialization to some degree of that information for the benefit of research and innovation. Um, and I think it's something that the new system, and I think NHSX, to be honest, was also starting to get to grips with. That actually we have to look at this properly. Look at the wealth of information we've got. Actually, you know what? If we can do something with that, which would bring in money to benefit the system, is that such a bad thing? Um, and so far as I understand it, has that was being looked at. I don't know how far they got because of the COVID pandemic, but it would make sense to me, especially given the rapid way that we had to create vaccines this time, that actually we have a really clear basis and a system within which we can start to take all of that information and use it properly. Now, if we want to anonymize it, it can be anonymized. Pseudo-anonymization causes a different set of issues that you have to think about. And equally, I know we've still got some issues relating from the European case on Schrems 2 and the use of cloud-based systems because of some concerns over the way that the USA and specifically could have access to that and privacy issues. But all of those we must be able to overcome so that actually we can create a really good database that is beneficial and we can have clear ways that people can use it and access it. But I think the other thing is within that, you need to create a clear set of standards so that the way the information is set out is clear for everyone to see. So we don't have information set out in different ways. There's one standard and that's what you follow. And I know all of that's being looked at, but I don't know how far along it is.
Thank you. Interesting one from Richard Dodds, who's asking whether ICSs will be statutory successor bodies, or he asks whether we're heading for a cliff edge, similar to 2012-13 when the legislation last changed, I think.
So I think in 2012, it was slightly unusual in that. So as I'm sure you'll all remember it, the initial proposal was that CCGs would be brand new bodies and would not get any legacy liabilities from PCTs. And then relatively late in the day, that position changed as we went on, and CCGs did take on the liabilities. I think in this regard, the ICSs will be the statutory successor bodies to the CCGs that then form them. I do know that legacy arrangements are being looked at. I know that DH have been asked to look at those urgently so that we avoid that whole cliff edge that Richard talks about. So hopefully that guidance will be out before we actually go into the new system. But I think that the ICSs will be successor bodies because it's probably the only way you can do it sensibly and have a clear line of accountability going through.
Thank you. So we'll just squeeze in one more question from Rachel Carter, who asks, Gerard, whether we've got any feel for place representation at a system level. I think a lot of people are interested in this, sort of seats on either of the ICS boards. One's a partnership board, isn't it, and the other board. Any thoughts about how they might be constituted?
Yeah, so I mean, when we've been going through this and we've been talking to our clients, then we've said to them, look, there are several different ways you can look at this. You can try and recreate um, the the kind of healthcare and partnership boards you've had, which are huge generally, and have everybody on there who wants to be on there, who's a kind of senior executive level. That I'm not saying that's a bad thing, but they're bigger boards, bit unwieldy, because how do you get everybody together? How are you making decisions? All of that kind of thing. I think what people can look at more is actually around the concept of, this is our board. These are the people who are the members that can vote. But actually, what we also want are people who can inform us of what's going on, because it's up to the chair who speaks, what they speak about, and whether a person stays there, even though you're going to private session. You don't have to kick everyone out. If you want people to stay there, they can. And so within that, you can think about people being in attendance. So if you look at, for example, the way Croydon has been run with Matthew Kershaw. So Matthew Kershaw, chief exec of the trust, is also the managing director from the CCG perspective for the place of Croydon, but doesn't sit on the governing body of the CCG, but does go in attendance. So he can give all the information, he can share it all. And the other thing with it, to be perfectly honest, so we have all of these wonderful discussions whenever we create any terms of reference or constitutions over voting rights. We spend hours on it. We spend more time talking about voting rights than you actually spend voting ever, because you very rarely go to your voting powers. You very, very rarely do it. And so I think people can look at that and can think about, okay, let's have a board that's actually got the people on we need to be on who have the votes, but actually we can invite other people to it to give us information. Or you could, from place, simply say that each place, depending on how many you have, gets to appoint one person who sits on the board. Now, it's fine if you have only 2 or 3 places. It's not so fine if you have 5 or 6, because that increases it all. So I think there are different ways to cut it. But I think one of the things is for your system to think about, what is the purpose of this person being here? And equally, how often are we really going to vote as we go forward? So I think it will depend on each system, but there's plenty that people can do.
Thank you. So I'll draw it to a close there. There are a few more questions in the chat box. So I don't know, Gerard, if we can pick those up offline and I can maybe circulate the questions and
Yeah,
answers afterwards, if
if
that's all
you
right.
if you send them over, I'll have a look at them and either go back to the individual, or I can send you a list of my answers and then you can circulate them.
Brilliant. Thank you so much. That's really, really helpful. So thank you once again. And I would just like to extend my apologies for my lack of capacity to manage and drive the team's presentation. So apologies if you couldn't see the slides very well. That's just completely my fault. So thanks all for joining, and do keep an eye open for an invitation to our next webinar, which is on the 23rd of June, when we're going to hear from somebody about his experiences actually in setting up an ICS in Mid Sussex and Essex area. So thanks once again, everybody, for joining, and particular thanks to Gerard. Thank you.
Thank you.
Thanks, Gerard. Bye.
Bye.